when someone finally understands that that person has a complex epilepsy, a drug-resistant epilepsy, what does the doctor has to do in order to actually cure it?
As I said again, whenever if your fever is not disappearing with the paracetamol after 3-4 days, you need to investigate.
Okay.
The same thing is, so there are fixed definitive criteria for drug-resistant epilepsies. Like if your seizures are not controlled by 2 drugs in full doses, or given in appropriate doses, appropriate drugs, and taken religiously by the patient with an acceptable side effect profile, and still
the epilepsy
and over a span of 2 years.
Okay.
So it's called a rule of thumb is 2. Rule of 2. 2 drugs for 2 years. And still your seizures are not controlled, then this is called drug-resistant epilepsy. And whenever the drug-resistant epilepsy is established, the earliest possible thing that's to be done should be evaluate the cause. Try to find out the cause. You may be treatable. If you can address the cause, your epilepsy might be completely treatable.
So the first step is the investigation.
So first step is labeling.
All right.
I again want to emphasize the labeling, that you need to label it as a drug-resistant epilepsy or a complex epilepsy, and need to talk to patients that, look, this looks like a complex epilepsy to me. It doesn't look like a simple, with a simple addressal that this is looks like a complex epilepsy, opens at least a door for the patient, or at least an understanding for the patient that we need to dig down to the cause. It doesn't appear to be a simple epilepsy. So the first thing I would say is a labeling by any primary treating physician. They should label it as a drug-resistant epilepsy. Whatever may be the cause, it just doesn't matter. Whatever may be the MRI report, just doesn't matter. Whatever may be the EEG report, just doesn't matter. The physician or even the patients should understand this pattern and should say, looks like it is a drug-resistant epilepsy. And this should happen within a span of 2 to 3 years. We should not wait for 10 years to say, oh, looks like we are looking at a drug-resistant epilepsy. Not a good thing to do. With the current level of understanding and clinicians we have, we should be able to label it within 2 years. Now, once you label the epilepsy as a complex or drug-resistant epilepsy,
Step 2
is finding out the cause.
All right, finding the cause.
Now, what happens? The standard procedure of evaluating drug-resistant epilepsies are generally called as presurgical evaluation, or is generally called as epilepsy surgery evaluation.
All right.
So generally a word surgery is attached to it, and that's why many people are afraid about it.
Oh, all right.
So, but I will call it a different way. Let it be called a pre-surgical evaluation or epilepsy surgical evaluation. It just doesn't matter, because nobody is going to operate you if they don't find a cause.
Yeah.
So the idea of pre-surgical evaluation is, most of the time these complex epilepsies will have structural cause in the brain, or identifiable cause in the brain. And as I said before, if you can take this out, your entire epilepsy can go down, and you don't need anti-epileptic drugs as well.
Yeah, because the spark is going away.
Exactly. So the idea of labeling this entire thing as a pre-surgical evaluation, based on the fact that majority of the complex or drug-resistant epilepsies will have some or the other structural cause associated with it. So now, the idea of pre-surgical evaluation is, there are fundamental questions we address in pre-surgical evaluation. The first question is, how exactly are the seizures?
All right.
And what is the clinical diagnosis of a seizure? Clinical seizures.
All right.
So that thing is addressed by video EEG.
Okay, video EEG, yes.
Right? So the pre-surgical evaluation will have 4 or 5 counterparts. We will come to that gradually. So the first question is, the clinical identification or confirmation of a diagnosis and where exactly the seizures are coming from. That question is addressed by video EEG. How?
So what is a video EEG?
Yes. So video EEG is the procedure where patient is admitted in the hospital. He is attached EEG and then he is put under camera for 24 hours straight. Or for that matter 2 days, 3 days, 4 days. Right?
Yeah.
And then we reduce the medicines so that we provoke seizures to happen. Because we have to record it within a short span. And then patient throws into a seizure. Then the camera records exactly which arm molded, which arm started first, whether it's eye, whether it's a nose, whether it's a face, whether it's a whatever arm arrangements. So by that we understand which area, probable area of the brain where the seizures are actually coming from based on the video of a patient. At the same time, there is a EEG recordings going on. So from the EEG, we identify which area of the brain the electrical activity is actually starting. So then if you look at these two things at one go, in a video EEG, you can reasonably establish the area of the brain from which the seizures are originating from.
Alright, understand.
So that is a clinical and electrical evidence of your seizures and the origin.
Alright.
Right? Now the next part in the process is a MRI. Now we know that this is the probable area. Now we do a very specialized high precision kind of MRI for surgical precision. I normally call it a surgical precision MRI to understand which is the area of that brain based on this clinical EEG and based on the seizures we recorded. So we focus on that area and we identify the structural malformation in that area. So that is a second evidence. So MR gives you a second evidence.
Well, actually, a third evidence.
So the first evidence is a clinical and EEG. The second evidence is a MRI, which is a structural evidence. Structural evidence, right? Structural abnormalities. Now the third thing is we do a PET scan.
So what is a PET scan?
So what does a PET scan? You give a radioisotope of a glucose and then we find out the glucose uptake by that area which produces the seizure. And generally it is less than the normal brain.
Alright.
So that's how we find out the third evidence if it is coming from the same area. Right? So we need, basically it is a complex thing. So we are trying to collect the evidence to say that your epilepsy is originating from this area of the brain.
Okay.
That's the entire aim of your pre-surgical evaluation or epilepsy surgical evaluation. And then the last part we do is a neuropsychological evaluation.
Okay. What is it? What
we do? Neuropsychological evaluation is our brain has, our various parts of the brain have various subtle functions that are not evident in day-to-day life. So we give a complex task to the patient where full of your brain potential is utilized in solving those tasks. And then you find out which of your brain areas are not functioning up to the normals.
Okay. Because there's where the cause.
That's where the cause might be, because wherever your cause is, that brain area is not functional. Right? So that is how we collect the fourth evidence to suggest that probably this part of your brain is the cause of your epilepsy. So these are the various angles. A structural angle, a glucose and metabolism angle, a clinical angle, an electrical angle, a deficit angle to focus on the same problem we are trying to identify. So this is a very precision medicine.
Okay, how long all this process?
So generally it takes 3 to 4 days to evaluate the entire pre-surgical evaluation, and we finish all the steps in 4 to 5 days. And then the last question is addressed during pre-surgical evaluation. What are the possible complications? Can we remove that area without producing additional neurological deficits? These are the most fundamental questions for any brain surgery. So the last question that is addressed in this pre-surgical evaluation is, how safe is surgery? What are the possible problems the patient can land up into after surgery? Or what are the possible neurological deficits? Or what are the kind of safety of the probable surgery? So these are the kind of questions we answer in pre-surgical evaluation. Now, as we have stated, there are multiple inputs involved. So clinical and EEG is reported by the epileptologist or a neurologist.
So multiple evidences.
Yeah. So this comes from a epileptology department. So MRI is reported by a radiologist. PET scan is reported by a nuclear medicine consultant. Neuropsychology is reported by the neurosurgeon. So there are multiple inputs involved to form a treatment for this kid or a patient, and a surgeon who is trying to establish the safety or a feasibility of the surgery. So what happens? Generally, it is not the single man's decision. All of them meet together in an epilepsy surgery meeting and they discuss. Everybody provides the input of this patient and they find out a common ground whether surgery can be offered to the patient, what is the success chances of epilepsy surgery, is it feasible to do surgery, what are the possible deficits of the surgery, and holistically, should we offer them surgery or not? So this is the end point of your pre-surgical evaluation is the decision whether what is the diagnosis, what is the cause, what is the probable treatment, what are the probable deficits you might land up, and is it really feasible holistically to operate upon this patient or not? So this is the end point of your entire pre-surgical evaluation.
All right.
So now I think we have cleared quite a ground.
So can you cite some examples, like real life examples that you have encountered? Without obviously saying any names or any specific.
No, of course, we almost operates. I mean, you know, we operate a lot of patients here, so every case is unique, and there are a lot of such examples.
For example, like yesterday case.
Oh yeah. So I mean, if you say that yesterday's case, she started epilepsy at the age of 1 year, one and a half year.
Right.
Yeah, and she's now 9 years, and for last 9 years or 8 years, she's constantly having episodes every day.
Every day. How many times a day?
4 to 5 times a day. She would go into a seizure and she would fall. She will injure herself.
All right.
She's on 3 or 4 anti-epileptic drugs, and then she developed little behavioral issues. So to control that behavioral issues, one more additional drug is there, and she was followed the same way for last 8 years.
She followed the same
anti-epileptic. I mean, she was followed on anti-epileptic medicines for last 8 years,
not working,
and nothing worked for last 8 years. Nothing worked, and she had a small cortical malformation, very small, like maybe a 2 centimeter, 3 centimeter cortical malformation, and probably if somebody would have caught her early and said, okay, this is a difficult or this complex epilepsy or drug resistant epilepsy, she could have been worked up early. That dysplasia could have been taken out, and she would have been in a normal school by now. She dropped out of school 2 years ago because she couldn't get there.
Focus.
You know that, right? We discussed that last time. So the idea is, if you can diagnose the cause, you can treat it early. So now maybe let us come to the maybe a later part of the discussion.
Sure.
So kind of let me give you a perspective or a rationale of epilepsy surgery. Many people are afraid. Many people are simply afraid of brain surgeries. So epilepsy surgery primarily involves taking out the part which is responsible, taking out a part of your brain which is responsible for your epilepsy. So there are fundamental assumptions for that.
There are, sorry?
Fundamental assumptions.
Assumptions.
Yeah.
Right.
for epilepsy surgery. So first thing is, the part you are taking out is mostly a cortical malformation or whatever it may be. It does not have function in itself because that is an abnormal part.
Yeah.
So it does not have a function.
Yeah. So removing it shouldn't cause any problem.
Yeah, with some reservations I would say, but yes,
Okay.
that is true. So fundamentally that is an abnormal part. Secondly, we, after so much of investigations, we can safely predict up till 95% that what are going to be the chances of your safety of the surgery or a probable deficits after surgery. In 98% of the cases, we can predict that probably you're not going to have any problem or you're going to have that problem. And the third part is the concordance, that all the investigation that we did so far, they are focusing on the same part of that. They're saying that same thing, that this part is responsible for your epilepsy. So these are the fundamental assumptions of epilepsy surgery. So now the surgical methods involves in and around of it.
Involves?
In and around of these fundamental assumptions.
Okay, right.
So now if you have a large area of the brain which is involved, we may not be able to resect out entirely. So we just go in and cut the fibers of it and disconnect it from the rest of the brain. It achieves the same result, but it's just the surgical technique, I would say, technical variation. So the idea of epilepsy surgery is to take out that part from your brain or disconnect that part out of your brain so that it doesn't affect your brain anymore.
So even if it sparks, the sparks do not shut your whole brain off.
Right, because they are disconnected.
Alright.
Just considered a switchboard.
Yeah.
So if you do not really want to disfigure that switchboard, so what do that? You open a faulty switch, cut the wires, close it there and put the switch again so that the person from outside does not make any change. It is not disfigured. But the switch is there, but it's not connected anymore.
Yeah.
So the idea is very simple. We just effectively, it's the same thing. Taking it out or disconnecting is the same thing.
Okay.
So the idea, So the idea of epilepsy surgery is this: taking out. Now, so these are called as, I will call, curative intent surgery, where the intent of a surgeon is to take out that part and cure you of your epilepsy.
Yeah.
A complete cure of your epilepsy. That is a curative intent surgery.
Are there any types?
Yes.
Any other types?
Yes. So there is something called as palliation surgeries or palliative intent surgeries. So when we see that if you have a damage on both the sides of the brain, or large area of the brain which cannot be taken out,
Or cut.
or you can have major problems with that. So then there is something called as palliative intent surgeries. Palliative intent surgeries means you may not get a complete seizure freedom, but you would be getting relief from the disabling seizures, most disabling seizures.
Okay.
Like it is like a partial relief kind of a thing, palliation basically.
You just stop the worst ones.
The worst ones.
At least you can have a normal life.
So there are many patients who are called drop attacks. So they will just slump on the ground from the standing position and they will injure themselves like anything. A simple procedure called as corpus callosotomy can take out the drop attacks by more than 90%. So the kid who is having 20 drop attacks every day would not have a drop attack for a month. So the injuries are going to be very less. So but you are not going to make him a complete seizure free. So they are called as a palliative treatment or a palliative treatment option. Both are equally effective or both are equally important. But this distinction is very clear that in some surgeries we are trying to with a curative intent. We know that it's very small malformation. You can take it out. You can be completely seizure free for life. So that's a curative intent surgery. Right? So these are the two types of surgery.
What are the rates of this surgery? Like for your personal experience?
Most of the time, 80% of the time we do curative intent surgeries, and around 20% of the time we do a palliative intent surgeries.
Okay. So,
roughly.
Nice.
So that's the types of epilepsy surgeries.
Okay.
Now let me explain you a very important fundamental philosophy here. That is a rationale of surgery. Rationale. Why a drug-resistant epilepsy person or a patient who is on 3-4 anti-epileptic drugs, who is not controlled by anti-epileptic drugs, there are two options, right? One is a continued medical treatment, and the other is surgery.
Yeah.
So
okay. So sorry for stopping you a moment.
Yes.
So we saw like